triathlon. I'm the short guy up here. And there's a silly picture, silly video. Is that coming through?
Yeah, it's coming through. That's awesome.
All right. Now off to stuff that some of the meat of the presentation. So in our clinic, Dr. Chimes and I believe that one of our prime goals is to stratify patients as quickly as possible to the right treatment. And we think that should be more or less all of our goals, is to, once we hear about a patient's story, quickly stratify them. We also believe that physicians shouldn't necessarily be the front line for musculoskeletal or spinal disease. So, I list here, a bunch of docs on the right, but we think PTs should be the first to see patients with musculoskeletal problems. And if something isn't going well within 4 to 6 visits of physical therapy, and a patient's not responding to what you're doing, at those times, someone may benefit from a more precise diagnosis and a referral to a sports PM&R doc. So again,
if I can interrupt you too, Garrett, like that's one of the things that I think so many of our therapists over the years, they've been at that 4 to 6 visit mark, and they're kind of like, if you're not seeing those results that you really expect at that point, that's when for all the PTs and involved in this tonight, that's a great time to refer over to you and to Gary.
Thank you for reinforcing that. So here, if the progress is poor and we receive a patient referral, then we start engaging in what we call the 3 Ds: data collection, leading to a precise diagnosis, and then shared decision-making with the patient. The goal ultimately is to get the patients feeling better and then back to physical therapy, because that's the way they're going to get back to playing their sport or back to optimum function. So our goal, our shared goal, now I'm speaking to, well, anybody in the healthcare team, frankly, is to assist the patient in tissue adaptation, allowing this injured area to accept more load. These are electron micrograph images of tendon, and the one on the right is disorganized tendon collagen fibers. You see how they're going in every which way and direction, versus the one on the left, which are organized collagen fiber bundles in what we call fibrillar architecture. So this is it's just good to remind us that the stuff we're doing on a macro level make quite a difference, in fact, on the micro level. So with ultrasound, we can see a ton. People ask me, well, what use is it? Well, we can see from skin down to bone. The sound waves cannot penetrate through bone, so we can't see deep into a joint recess, but we can see the periphery of a joint recess even and assess things. But it's wonderful to assess things below the skin. And we all know that as good as we get, as seasoned as we are as practitioners, even if you see a shoulder, that it can be confusing to know, is it a rotator cuff issue, a simple dynamic impingement? Is there something with the bicep tendon? Is it an arthritic AC joint where the part of the joint below the skin is affecting the impingement? It's hard to tell, but that's why it's sort of like an iceberg analogy, where you can see the stuff you can see on the surface does not necessarily tell you what's beneath. So there are times when having an advanced imaging technique makes sense. Ultrasound is quite remarkable, and don't just take my word for it, but I'm going to show you guys that a picture of like tendon and the sizes, the diameter of tendon is between 100 and 500 microns. And that an MRI is able to resolve tendon at about the 450 micron level. And so MRI is good at seeing the entirety of a tendon, but it doesn't resolve the smaller structures inside the tendon, like the fascicles, the fibrils. Ultrasound can see down to nowadays 50 to 100 microns. So it's incredible high resolution. Whoops, I'm going to go back here. Incredibly high resolution for so much more detail. So for those of us that like to treat tendon, ligament, fascia, we can resolve that down to such a different level than MRI. It's the best imaging technique for that. Here's an example. So on the top, we have an MRI. It's an image where it's a sagittal image. The patella or kneecap is up here. This is bone, this is the femur, and then the tibia is here. But look, this dark structure here is the patellar tendon. It's a normal appearing patellar tendon on MRI. So I'm running over. Can you see this okay with my cursor?
That's great.
So, all right, below we have the ultrasound image. So in the ultrasound image, bone will show up as a bright white line with dark shadowing beneath. The edge of bone is the cortex of bone. And so the patellar tendon starts here at the inferior aspect of the patella, inferior patellar pole, and then goes down to the tibia to the right. But look at what we can see of the tendon detail. We see tightly pressed together these collagen fiber bundles, alternating bright and dark lines that we term fibrillar architecture. So we can see it and resolve it with incredible detail. Here's a shoulder example. We'll look at the supraspinatus. So up top is a little diagram, supraspinatus muscle, myotendinous junction, and then the tendon connecting to the greater trochanter. Here's an MRI image, muscle, tendon here at the end that's black. This is normal appearing and attaches to the greater trochanter here. So the detail we see on MRI is that it's black, but on the ultrasound to the right, this is now the greater trochanter labeled GT, and here underneath the arrows, but right in here is the substance of the supraspinatus tendon, again with alternating, tightly pressed together, bright and dark lines in a very organized fashion, as that we'll call fibrillar architecture. And you can just follow and imagine these tendon fibers or collagen fiber bundles going into the bone here. And this is normal. If it was abnormal, like a tear, we'd actually see sometimes see at the bone, it would be an irregular line, it would be a broken up line, and we'd see dark areas often in the tendon, but that's normal. But just to show you what detail we can see. The other thing is ultrasound is dynamic. This is a view of an impingement view, we'll call it. The bone here to the left is the acromion. This down here is the humeral head and the greater tuberosity. This is the supraspinatus tendon. And this dark stuff here is fluid in the subacromial bursa. And so we're able to see things, again, like beneath the skin. It's like looking at the part of the iceberg you can't see. So our goal is, when we have people in the office, is to collect enough data to narrow down the differential diagnosis. So one interesting type of case is like we'll see people commonly with back, buttock, and leg pain. How do we differentiate between S1 radiculopathy, SI joint pain, proximal hamstring injury with pain referral into the leg? And so our goal is to, of course, do a physical examination, then decide what types of imaging tests will help us to decide that. We still, even though we're experts in musculoskeletal ultrasound, we still order plenty of x-rays and MRIs and whatnot, because each of our tests has different strengths. The ultrasound strength is to look at the soft tissue like the proximal hamstring, hip rotators. We can see a proximal hamstring tear can cause true sciatica because the sciatic nerve is right next to it. So in any event, the ultrasound is terribly interesting. Back to some levity. This is a little slide to explain the evolution of a musculoskeletal physiatrist. Well, we start kind of hunched over. As a resident, we only learn how to take care of musculoskeletal issues, prescribing, rest ice compression elevation and NSAIDs. Whoops, we get a little bit smarter, and we're a fellow. We prescribe NSAIDs and understand some of the basics of exercise. When we're a young attending, we're a little more upright, and we've learned about steroid injections at that point. And then when we're more evolved young physician, We understand the value of PT. We still prescribe NSAIDs, perhaps do steroid injections, some ultrasound guidance. But when we're a fully marinated physician, we use diagnostic ultrasound guided procedures, and we have some familiarity with regenerative medicine or orthobiologic techniques. And then, of course, we start going downhill. and then we become a devolved MD, we'll call it, and we might choose to be, hospital administrator, medical director for an insurance company. Okay. And so, we have dual goals in our practice. One is to keep our doors open and, earn a living. And the other is to pursue happiness. And so the use of ultrasound plays a role in that because, this is something from a presentation we did at our national meeting once, but what is happiness? Well, immediate joy or pleasure, like watching your kid hit a home run or score a goal in soccer or take a bite of a delicious tiramisu. Or level 2 happiness, which is more relative, like where you're comparing your state in being in life to other state, and you think, hey, I got it pretty good. And level 3 happiness, where you're really trying to achieve personal growth and potential and mastery. And that is what ultrasound, that as a tool has helped us to achieve more of a mastery of musculoskeletal medicine. And it's a tool that helps us to grow every day. So just want to insert that.
Well, can I comment on that real quick? And that's, I know
please.
as you kept evolving in your machines, and I think just your deftness of doing the sheer number of ultrasounds, I think like your diagnosis, I've noticed over the last 20 years, just how the diagnosis got more and more specific and more, and with that specificity, I think it helped the physical therapist. And so the efficacy of like the care the PTs, provide and what you're recommending, I think is just continue to, I don't think it was quite the Neanderthal or early primate level, but when I first met you, but I think it's evolved just like, medicine has in general, but I think it's been a big, kind of wind to your back as far as your diagnostic ability and your treatment.
Yeah, I was pretty close to Neanderthal, let's be honest. It's funny, but I really, again, it makes me feel grateful for the making certain choices along the way, to work with my former colleagues at Northwest Spine and Sports Physician. I've had great mentors, so I'm really lucky. Getting back to this, some of the bonus things about musculoskeletal ultrasound, some of this I've mentioned. It's quite high resolution, it's higher resolution than MRI. It is low cost. It is dynamic, gives us exquisite detail. It's point of service, and we can use it to guide procedures. So on an interventional basis, we know where we're going to get the needle tip and know where we're going to deliver and injectate. And we can treat so many things with great accuracy, which helps. Even if the procedure doesn't work well, we're sure we did something where we intended to that still helps in next steps, because things, of course, don't always work. And some of the things we'll use it for, I've listed here on the right, like whether it be on occasion, I didn't list here steroid injections into a bursa. We'll still do that now and again, but we're using more and more things like platelet-rich plasma, prolotherapy, micronized fat, and other things, including something called Tenex, which I'll touch on in a bit. And it turns out that guidance matters, because all of us physicians, including I think nowadays anyone in residency programs, learns, other than if you're an interventional radiologist, you're doing injections by landmark guidance. And it turns out even for a joint like the acromioclavicular joint, now this is superficial, we can feel it, we can touch it, and it's still, we're woefully inaccurate at getting the medication intracapsular, so beneath the capsule. So it's pretty astounding, but we're much, much better with ultrasound guidance.
Well, and I think if you want just a quick example of how different that is if people had multiple shots for COVID, how every single shot was differently placed. Some would get you in the AC joint and almost give you a frozen shoulder, and some feel like they didn't really do anything. So it's and that's people doing hundreds and hundreds of shots a day. So that gives you a good feeling on that guidance and landmarks.
Yes, sir. Absolutely. So now off to some cases. So this first one will be about an Achilles, and the first slide is really just showing that this is an ultrasound image of an Achilles in what we call longitudinal view, and this is a transverse view. And this is the calcaneus here. So bone again will be a bright line with dark shadowing beneath it. And this is the tendon insertion, and this is the mid portion. And Achilles tendinopathy, we tend to divide it into an insertional or a mid portion concern, and the treatment is different. Again, here are the subtypes. And, there's some really wonderful guidelines for loading, and, the Alfredson protocols for eccentric loading, and nowadays heavy slow resistance, so loading both concentric and eccentric protocols. If it's a insertional tendinopathy, not dropping your heel below the step, like in this image, would be treating more of a mid-portion tendinopathy. But here's some ultrasound images, and here's what we do to a recalcitrant tendinopathy when it's not responding to therapy. This is a markedly thickened tendon in cross-section, so it should look more homogeneous, a little brighter in none of these dark areas, and this is probably twice the thickness. And then this is color Doppler, which shows increased blood flow, and the Kager's fat pad, which is just in front of or ventral to the tendon. And this rolling image just shows some other very dark areas in the mid portion of the tendon. And this is another image showing how, when I get to right about here, some of these dark areas are tendinopathic. So that we have a variety of treatments actually to help people who have a painful Achilles tendinopathy that are not improving or just can't progress in therapy. And this is one of them. This is called the ventral fat pad scraping technique. And so this is, it's kind of neat to look at because you can clearly see the needle, including the bevel, very well, scraping off the ventral Kager's fat pad. And we'll often use high volume saline and anesthetic to separate it, because there are abnormal blood vessels and nerves that grow through the fat pad into this part of the abnormal part of the tendon, and that's what supplies the pain. And if we can often get the pain to go away immediately, like it's right at immediately from the procedure, and then they can get back to their loading with PT. Next case, jumping to a knee now from an older person to a younger person, 11-year-old soccer player who had an apophysitis, or so a pain at the proximal patellar pole. Someone who'd been in PT, premier level soccer player, returned to sport prematurely. And this is the patella. I'm sorry, the patella is here. This is the patellar tendon. And the cortex of bone should look pretty smooth, even than apophysis. But you can see here, we can see the detail of bone and an elevated or raised cortex, which was abnormal. And this is a dynamic image, but I think it's interesting to see there was increased blood flow at the apophysis. And the combination of raised cortex and increased blood flow and the exquisite tenderness and the whole picture helped to stratify this person to treatment where they had to be shut down. As you all know, with these elite athletes, even the young ones, they're pushed to do more and more in short periods of time. And sometimes sometimes we need to get some evidence to say, no, you gotta stop. And this was one such case. Interesting case here, another knee pain. I think about a 30-year-old guy training for Olympic weightlifting competition, went to a squat, felt a pain. It was posterolateral. There's no knee swelling or mechanical symptoms. And ultrasound showed this dark thing. So this is the posterolateral meniscus. And the meniscus cartilage on ultrasound should look homogeneous in this kind of shade of gray. and there shouldn't be this dark thing. And so you see this, there's another image up here where we see a serpiginous or cleft, dark cleft. And this is another view, but it was, I was able to diagnose a posterior horn lateral meniscus tear. This one was a super interesting case, but a little more on the bizarre. It's not like important to remember necessarily, but it was a runner. He's had a prior meniscectomy. He would have sort of arthritic pain. At another center, had landmark guided viscose supplement injections, hyaluronic acid, and then developed some some anterior and superior suprapatellar pain, and had some fullness at the distal quad, and where the arrow is, like there was kind of a lumpy area, which was in the mid portion of the quad tendon. Under ultrasound, this is this contralateral normal tendon here, more uniform architecture, all this in cross section. This dark thing is very tendinopathic abnormal tendon. And in longitudinal view, this is all, it should look like this here, but this whole section was dark, and presumably the hyaluronic acid was injected into the tendon. But we were able to make the diagnosis, and he responded very well. Actually, the loading is tendon. Sorry if I'm going fast, Ben. I just have fun things to share. So the next one is a runner, 69-year-old with buttock pain, persistent. And this is a cross-section across the ischial tuberosity by ultrasound. So this is the cortex, and there's dark shadowing beneath bone. This here, that's a little brighter, is actually a calcific body in the proximal hamstring. And the calcification is right here. We ended up doing a needle tenotomy to break up this calcification. And you'll see this, it's still this size roughly here. Next image, still working, but it's now into bits and pieces. And the next image, we're injecting some PRP. And this person did quite well. I was able to return in 6 weeks back to running. And another case of calf pain in a runner, and tennis player, tennis leg, we see quite commonly.
Or pickleball leg.
Oh gosh, for sure. Thank you, pickleball, for growing so rapidly, helping us with our livelihood. So on ultrasound, so this is muscle architecture in the medial gastroc. It's what we call pennate architecture, and the muscle fiber bundles come and connect to what ends up being the starting with the Achilles tendon. But there's a black area of fluid collection, hematoma. This is actually same patient, but found some fluid in the popliteal recess that I don't think was causing any symptoms. But there can, in the differential diagnosis, you can have a pain referred from a Baker cyst into the proximal calf. And they had a small Baker cyst, but I don't think it was symptomatic. But these videos show like the needle into the hematoma. This is sort of early on, and this is later aspirating all the fluid. And it helps people to heal when they have a retained hematoma that's not improving quite quickly. It seems to reduce their time to return to play, at least by half. So here's a case of posterior medial ankle pain. And there was a person who saw podiatrist was diagnosed with tarsal tunnel syndrome. They did have a pain referral like around the ankle down to the bottom of the foot. I understand why they were given the diagnosis. Diagnostic ultrasound ended up being helpful. This is a tendon coming across with a tendon sheath effusion. This is the FHL, or flexor hallucis longus. Oh, I'm sorry. Good. And pardon my dog, Rainy. This is the Zoom world, though it happens. So this points to, it's an axial image, and this is the FHL tendon with tendon sheath effusion. And then this is the left versus the right. And over here, you can see this trailing larger dark area, which is the tendon sheath effusion in the FHL. This is going to show you some dynamic gliding, because we can bend the toe up and down and watch the tendon glide. It's quite elegant to watch. And you see that fibrillar architecture we were talking about with the organized, tightly pressed together, alternating bright and dark lines in parallel. And then I did an injection. The needle's coming across into the tendon sheath. You can see the needle now right beneath this tendon. By the way, the tibial nerve is right up in here, the tibial veins. So injected into the tendon sheath. This is you can see then fluid moving around the tendon inside the tendon sheath, and it calmed down the tenosynovitis, and the patient did well. Isn't that always the answer, though? The patient did well.
I like
Another case, it's fun just to talk about because we've seen a ton of it, is you alluded to earlier, is frozen shoulders. And we've seen so many more of them, it seems, since the pandemic and during the pandemic. We have a cute video, I think, on our website that one of our former employees who used to work, or maybe still does, as a Disney princess on the weekends, dressed up in costume for us, and we did a cute video. She was Elsa, and we did a frozen shoulder. But it's been common. It's thought to be a inflammation and thickening of the capsule, but we're not sure the etiology exactly, but it seems to have an autoimmune component. But we do I think, a unique procedure in the community. There are people, probably a bunch of people in the community do glenohumeral injections or glenohumeral hydrodilation or Briesmann procedures. But we combine three things into our procedure, and we think it works better. All these things are independently validated, but just not always done together. We do a suprascapular nerve block. We do the glenohumeral hydrodilation with high volume saline, as well as finishing up with anesthetic and steroid in the glenohumeral joint. This just shows a needle going under the joint capsule, and there's going to be like you'll see a little fluid coming right into here, shooting into there. So yeah, this is a pretty unique case, and we can see with ultrasound, we can see calcifications in tendon quite well. So calcific tendinopathy, particularly in the shoulder, is more common than you think. And when you have that patient who's got like pretty intense pain, but not a great mechanism for a cuff injury or whatnot, and they're struggling more than you'd expect. Like we'll see this maybe once a month or so, that someone's got like a really big piece of calcium in their cuff. There's an X-ray. This is some calcium here, extra calcium here in the cuff. This is a diagram of what these two things are diagrams of what it might look like. This is a cross section of the cuff, as is this. And bone, again, will show a bright line with dark shadowing beneath it. This is actually rotator cuff, and it should come all the way across, but we're seeing extra bone in here with dark shadowing. So, we can detect that very readily. This is a lot of calcium in this person. And we have different procedures we can use for it. And something called calcific barbotage, which is we inflate with saline and try and aspirate bits of the paste-like substance inside the calcification. It's actually a hard shell and a softer center, interestingly enough. But there's another procedure called 10X that is really interesting because it's a needle that vibrates at the tip, and it breaks up the tissue, and then it irrigates and aspirates at the same time. So these are a couple of videos of the 10X procedure into the calcific body, and I was able to get the majority of calcium out, much more than with calcific barbotage. And then, the after was, there's still some speckled calcifications, but the tendon looked quite a bit better, and person's just gradually getting, quite a bit better and back to rehab. Like most of these things, this is a procedure where we actually leave holes in the tendon. So there's a more deliberately prescribed rehab procedure where we're giving them rest for the first week, and then a gradual return to loading. But that's interesting.
You guys always do great. You do a great job of giving the therapist a lot of guidance on that too. So that's something that's always nice. So if you don't have that when people arrive, whether it be from like Washington Sport and Spine or another physician, I'd always recommend a call on that, especially that 10X procedure. One quick question too on the calcification kind of cohort that you're seeing there. What is there any common etiologies or any common job habits that you're kind of seeing with that group?
No, we actually still don't know why some people tend to get calcific tendons. It can happen after trauma, like presumably in some people, there's some small injury in the body has an over robust healing response. And for some reason they form calcium. And there are times when I see, a symptomatic side with calcific tendon, and then I'll check the other side with ultrasound and I'll find they have some calcifications asymptomatic on the opposite side. The etiology is still not clear, but it seems to be some people get it more than others. All right, next case. So this was really interesting, and actually someone asked, I think, a question about this, that this answers. This was a 12-year-old crossfire soccer player, defender, who valiantly stuck his leg out in front of the forward who was about to shoot the ball, kicked the ball away, but got kicked in the lateral calf, had immediate pain and some limping, was not able to finish the match, had an x-ray that was normal. This is the x-ray. There was return to play, and did return to play, practice, and then in another game got worse and worse and had to come out limping, really upset. So with ultrasound, I was able to see, this is the fibula, and this is the cortex of bone. And so this part is normal here. This line with the muscle coming like almost all the way up to the bone. And then you'll see there's the elevation of what is the periosteum, and all of this area with this dark line, white, dark, and light line is elevated periosteum with fluid and swelling in the fibula that I could detect. And it was like, I could see it, I could palpate, and that's where he was tender. This is it's a cross-section view, dynamic view. Now, this is normal cortex of the fibula. It's just a smooth, round, bright line with dark shadowing beneath. Versus here, you can see there's this other white line up here with darkness. It shouldn't have this appearance. And this person turned out to have a fibula fracture.
Oh, jeez.
I did get an MRI. So like sometimes I'll get asked, well, does ultrasound take away the need to get other testing? Well, not always. In this case, it did not. I wanted confirmation, frankly, but it absolutely helped me to give him and his family direction immediately that I thought it was a fracture, and to rest him immediately. This is an interesting case because this is a 18-year-old female swimmer who had a car accident. And she has had persistent back pain over more than a year, and is struggling in her butterfly stroke particularly, and shared patient with wonderful PT she on MRI she had this is L3-4 level, and this is the left L3-4. Excuse me, this is the right side because. And this is left, but the right L3-4 facet joint has this white stuff is extra fluid or an effusion in the joint, which is where she was tender, and on extension, we could recreate the pain with extension. So we elected to do a PRP injection under ultrasound guidance into the joint, and this is some anatomy we see on ultrasound of the spine. We don't use ultrasound to as the first line to diagnose issues in the spine, but we can use it for interventional things. And this is in cross-section, spinous process, and this is the spinal canal beneath the bone. This is the lamina. Here, this is the spinous process and lamina, and actually the lamina and superior articular process, inferior articular process. This is actually the facet. So we can see the facet and do injections, and this is image of this person's right LWPT facet. This is the superior, this is the inferior articular process, and this is the capsule edge. This dark stuff is actually fluid and part of that effusion. So I can see the capsule edge to do a procedure, and this is the needle coming down here, this shadow to the facet joint. And this is I guess I have a video where the needle is coming into inject the PRP. All right, and that is all my cases. I feel like I've rushed through, but I wanted to cover some of these fun things because there's such a wide range of how we can use ultrasound in our practice, like from head to toe, to be honest. And the sky, it's sort of the sky is the limit. What the limit is the doc or the person who's holding the probe. And I'm learning every day and becoming a better, physician as a result of this passion and interest. Can I pause a second? I'm afraid my puppy is going to have an accident.
Yep, absolutely.
Reflect on the piglet.
I think this is, one of the unique things about Dr. Hyman is not the puppy action, but is the fact that he does the diagnostic ultrasound himself. So this isn't a tech doing it. This is not an assistant. He's actually sitting there reading it real time with the client. So I think that's a very big distinguishing factor versus some facilities where you'll have someone else kind of do it, and the physician might come in halfway through or later, or so I think that's a helpful thing for sure. Are you ready for some questions? There's some questions that came in before, during.
Yes.
So I'm gonna
absolutely.
I'm
should I stop the screen share?
You want you to go ahead and stop the screen share. And I think you kind of touched on this, but this is one I think that is great for all the therapists that are currently here and that will watch this later. And that's, when should a physical therapist, athletic trainer, any kind of allied health professional, when should they seek out your services, or when should they kind of think in their mind, like, this thing probably needs a diagnostic ultrasound?
Well, like someone who's seasoned like you, and I find that this is an important question for the younger practitioners and PTs, because I think it's sometimes hard to have an expectation when you're new about how someone should be responding to your therapeutic exercise. But I said earlier, roughly 4 to 6 visits I like to use as a general rule of thumb, and I counsel patients that they shouldn't expect to be 100% better and cured in 4 to 6 sessions. But by that time, and in a discussion with their physical therapist, they should be able to identify something that's changing. Absolutely. And especially if they're compliant with their home exercise program.
Right. I think that's the biggest thing is, as for new practitioners, they almost expect sometimes people to be better by the 3rd or 4th visit. And it's actually, physiologically going to take longer than that. But like you said, there should be some kind of therapeutic effect that's taking place. It could be even that there's a little more soreness, but their function's better, or maybe their function is better, which is causing more soreness because they're back kind of more to their normal routine. But 100% agree with that. Maybe for some of the PTs, what's the best form of communication with you to send people to you? So if you were to, like, a PT, they many times asked me this, is like, how do I send someone to a specific doctor? What's your favorite mode of kind of communication? Is it, the PT calling you or faxing you or emailing you, or what do you like in that regard?
It can work. It depends on the case. Like, if there's a complicated case or a case where there's some yellow flags in terms of patient expectations or things patients have said to you, like some, if they've seen a number of docs, but you might suggest they see me or Dr. Chimes, and
it's 7:49 p.m.
Sorry, it's Siri listening in. So if if there's something odd about a case, I would love to have someone call me or send me a text message I personally am a little slower to get to emails, like takes me a little longer, but a call or text message for me is preferred. In a routine case where you just think, yeah, they're just not responding, but there's nothing unique, particularly about the case, just sending them over to our office is just fine, like to our office phone number.
Okay, it's always kind of nice to have, nice to know.
One thing I will say, and Ben, you know this because we've done this with a number of the newer PTs that come onto your clinic, but Dr. Chimes, I love having PTs shadow us at times, like for dual reasons. I mean, we love to meet and get to know the PTs and ideally even get to know what their particular interests are. And then we love to have them see how we interact with patients. And Dr. Chimes and I have like really different personalities and different strengths. We actually have very similar ways we think about assessing patients, but we're still different enough that sometimes it's good to shadow each of us because ideally we want to stratify people to good partnerships in their healthcare team.
100%. You guys have been so gracious for so many years on that. It's almost a rite of passage for our new therapists as they come on, no matter what their experience level is, they come and spend a day with you and Gary. There's no better way for a therapist, no matter if it's with you guys or any orthopedic sports medicine group, to know who you're sending patients to, as far as for both sides of the equation. But I think for our therapists, I think all the physicians in the area do a great job, but it's what, like you said, personality wise, injury wise, if a physician has a special interest in hiking or pickleball or soccer or whatever it may be, you kind of know there's going to be a natural kind of connection there with the patient. So that's a huge thing. And that's something I recommend, even with a lot of our aides that come in with us and they're spending time with us for a year. It's like they can get in with the physician groups and kind of see what's going on. And they just learn so much so quickly. One question I get many times from runners is, what about stress reactions, posterior tibialis tendonitis, tibialis anterior tendonitis? Is that a good diagnostic ultrasound candidate for you guys, from what you're seeing?
Yes, absolutely. So as the case I showed was a bone stress reaction, but our ability to look for, tendon issues, tenosynovitis, tendon tears, even micro tears, is really great. Now there are many times where we'll look with ultrasound, or sometimes we won't. Like there's sometimes we think somebody that the best test is not ultrasound. So not everybody we see gets an ultrasound. I'd say, in fact, like the case I showed with the fibular stress fracture, I did that. I only threw the ultrasound on because it was a little bit of a weird case where I thought, like, it seems really like a fracture, but he'd already had an X-ray and I have it as point of care. So there are times I will, but if something's more chronic in a runner with potential bony stress response, most of the time we'll get an MRI to look for changes in the tibia, which is what's common. But yeah, like there are people with chronic compartment syndromes, like diagnostic ultrasound. There are some findings we can see there, but I think it's most valuable even for treatment. Like if we can isolate what we think is the right compartment, we can even do these ultrasound guided fasciotomies that can help people with those types of symptoms in runners.
And maybe, like as far as the entrance into the system, what makes the most sense in your mind is, if you've had a primary, for a PT, I guess is a good example, and you've seen a primary care physician, they've had an X-ray, there's no fracture, whatever joint it may be, would the logical step then for some cases be ultrasound kind of prior to MRI, or help confirm that the necessity of the cost of the MRI, if someone's kind of has a higher deductible or that sort of thing?
It's very case dependent. Like I think at least when we're assessing people, there's no formula. We've gotten good enough with ultrasound, like even the case I showed with the raised periosteum at the fibula, I would not, like, I couldn't have done that 10 years ago, to be honest. So, like, even though I started ultrasound, like, doing it in about 2007, I couldn't have done it. So the way I use it today is different than the way I used it 5 years ago. But I'll say that one thing in our clinic, we're so eager to get as precise a diagnosis as possible that I will order any tests I think are prudent to, because most of the patients we see, we screen our patients for activity goals when they first call the office. We're trying to see people that are motivated in some way to engage in their rehabilitation. And so that we get a subset of people who are generally motivated. And if they're not, and hopefully they've already seen hopefully they've already had PT. And so at that point, it's not uncommon that I'll do an ultrasound if it's something I think that might help, and then same day order an MRI.
Right. That seems logical to me.
Another reason I order MRIs, like, so is shoulder ultrasound. It's a great use for it. Like, and I can find full thickness. I can find rotator cuff tears quite readily, but so can Rainey, my dog. But I can find the tear. But I also, and then I tell people if it's full thickness, hey, you need to see one of our surgical colleagues, and I'll make the referral. But the surgeons, at least to my knowledge, and I'd love to be corrected by them directly if I'm wrong, but they won't work off of my ultrasound exam because they're used to assessing with MRI. So I will, even if it's not necessary to confirm the diagnosis for me, I will sometimes order scans if I'm referring them out because I think they need surgery.
Yeah, right. And then trying to make that decision. I think like the MRI versus the MRA so many times, because what we've seen in so many clients, they get like a stipend of one MRI, and sometimes it's used by the primary care and there's no arthrogram, and so then we don't know if the labrum's, so then you have to, it's quite a process. Yeah. So I think getting into the hands of a specialist sooner, like with you guys or with, is always a good step versus trying to handle it just as a PT primary care. Like sometimes that it can be a tough stuff.
That's true. Sometimes I'll get the question, just to follow up, like where a PT will ask me, well, what happens if the patient was sent to the PT by a primary care, or even another doc who practices some level of sports medicine, but there's concern that they're not getting, all the testing they need, or they're just not getting well. Those are awkward situations, but I think, most doctors I know that are specialists are comfortable with when a patient wants a second opinion, so I think if in a conversation with a patient, they know they're not progressing and they have concerns, it's fine to say, and I would just say directly, reach out to the referral source and say, they're not responding. And especially if it's a primary care doc, I think the primary care docs generally would prefer only to hear that they're doing fine. Like if they don't want you to send them back the patient because they don't necessarily know what to do next. Right. So I would, feel comfortable as a PT making the referral and just doing what you think is best for the patient. Most of the docs that you probably want to work with have that philosophy.
Right. I think PTs feel the same way, as far as like if someone's not progressing under my care, then that's the reason we reach out to our physician specialist as well. I've got a couple of lightning round questions here for you. So some people
before we do that, there's a question in the Q&A where someone said all insurances pay for diagnostic ultrasound. The answer is yes.
Okay.
I have not found one that doesn't.
Good catch on
lightning
round here. So I don't know how well people know Dr. Hyman, but you can read more about him on the Lake Washington Sport and Spine website. All those details will be in the notes below. But favorite local hike?
I would defer to my daughter, who is a lover of our Pacific Northwest hiking on that one. So my favorite local hike is one that I'm doing with my daughter, Alexandra.
Oh, that's a good dad answer right there. I like that. She make sure she watches this later. Soccer or football?
Depende en quién está hablando. I like to speak Spanish, but football usually.
Okay.
Usually.
Pele versus Messi?
That's interesting. I actually think I did get to watch Pele play live in New Jersey in like 1978 when he was in the New York Cosmos.
The Cosmos.
I still have a special place in my heart for him, but I've watched Messi so much more, and he is a magician. So I'm going to have to go with Messi at this time.
Yeah, and very unassuming body type. Most memorable soccer game?
All right. Well, embarrassing. The U.S. medical soccer team years ago, we hosted the event in California, in Long Beach, and we were playing the Ukrainian Ducks.
Oh.
And I was subbed in. I was playing both the old man team and the young team, and the young team had so many injuries they needed me. They threw me in at forward, and I was a corner kick where I was basically trying to distract the keeper. Did that successfully. I ended up scoring a goal on that, and that we ended up coming in third. That's the best finish ever in a tournament for the U.S. team. So
there was no glory to the defender that day for them. That's for our Ukrainian friends out there. Favorite sounder, current or previous?
Well, someone who's both Freddie Montero, who was both from the beginning in 2009, and I just like his style quite a bit. But I also have to give a couple other shout outs. I love João Paulo. I think since he's been back, he's really steadied the entire midfield, and the team looks much better with him there. And I'm a big Jordan Morris fan, being from Mercer Island, knowing his dad, who's terrific and has given so much to the Sounders soccer community by being the team physician for so long.
JP is just a great human being too. So you're also a musical fan here. So Rent or Hamilton?
525,600 minutes. I love Rent, but I appreciate Hamilton. Hamilton is, as a contemporary thing, like, it's an amazing musical, and you mentioned that you're going to see it soon. I hope you find it that way. You probably listen to music. There's something incredible about the creation of that show, but Rent was one of the shows that I first fell in love with some of that music. So
very talented show. Yeah. Cats or Les Mis?
And I said this to you earlier, I'm going to have to go with Book of Mormon.
Book of Mormon is strong.
It was not one of the options, but I just also, I love the levity and the silliness of that show, which also has some pretty great songs.
And two more tough ones here. Hugh Jackman or Sean Hayes for just versatility?
You know what? So Hugh Jackman is on my wife's list.
Oh, geez.
I'm going to have to go with Hugh. Hats off to him.
I think he's on Ryan Reynolds' wife's list as well. The Leonard Bernstein or Andrew Lloyd Webber?
Oh, that's a really tough one. I think I'm going to go with a little more old school Leonard Bernstein.
Thought you might go off the board and go to Gershwin or something.
Yeah.
Well, thanks. In closing, I want to kind of thank everybody for hanging out tonight and watching this. You can also let your friends and colleagues know that we'll have this on the YouTube channel for Lake Washington Physical Therapy, hopefully later tonight. We'll be monitoring that too. So if you have comments, you can ask your questions there too. So let people know if they have questions after kind of watching some of those videos again, and they want to have a further breakdown. We'll be monitoring that, and I can get that information to Dr. Hyman as questions or comments come in. Make sure to like that and subscribe, of course, because you'll see other lectures, webinars, things that we have on there as well. And what's the best way to get in touch with you? Do you have any preferred contact for PTs and professionals?
preferred contact would probably be my phone over email.
Okay.
Yeah, I had a slide with that, but what's the best way to?
So we'll put the phone number for the office in there too. And then social media handles, like Washington Sport and Spine's got a social media that they have on Instagram and LinkedIn and Facebook.
That's right.
So we'll have all that information and links below, but I can't thank you enough for taking the time. I know you're super busy with the family and with the practice and seeing patients and everything. So it's always good to connect. I wish you're one of those people that I wish I had, more time to connect with more frequently. So I apologize if it's on my end. But anyway, say hello to the family and to Gary, and I really appreciate you doing this.
Hey, much gratitude for making the opportunity, and it's a lot of fun. And I look forward to many more such collaboration opportunities in the future.
Awesome. Well, here's to another 20 years. So we'll need a better filter for us by then. So all right.
Yes.
All right. Well, thanks so much, and we'll be in touch soon.
Okay.
All right.
Take care.